Have you talked to the people around you, the people that care about you? If there's an agreement between, if your grandparents think you're better, and your partner thinks you're better, and you're getting along great with your pets, and it also seems like it's helping you, well then, that's pretty good evidence. If it's just you and everyone else is like, please stop microdosing, man, you're not, and you're like, no way, I'm the best me, and everyone's like, we're not talking to you anymore. That's not great.
All right, we are thrilled to have Dr. Zachary Walsh as our guest today. Dr. Walsh is a distinguished clinical psychologist and professor of psychology at the University of British Columbia. He directs the TRIPS, the Therapeutic, Recreational, and Problematic Substance Use Lab, as well as the Problematic Substance Use Clinic at UBC. Dr. Walsh is a research affiliate with the BC Centre on Substance Use and a member of both the Advisory Board for MAPS Canada, us, and the International Research Society on Psychedelics. His therapy focuses on the intersections of psychedelics, cannabis, mental health, and psychotherapy. Welcome, Dr. Walsh.
Thanks for having me.
Awesome. My first question for you, sir, is tell us what you're up to.
Oh, yeah. Thanks. It's nice to be interviewed. Glad to be here. What I'm up to, in the psychedelic space, we've got a couple projects going on. One, we're just getting ready to start recruiting. Hopefully, I guess late summer, early fall, for our trial of psilocybin-assisted psychotherapy for opioid titration. So it's for folks who don't have opioid use disorder, but who are trying to reduce their use of opioids and prescription. So it's going to be folks with chronic pain who have longer-term opioid prescriptions, or are now trying to titrate down, and who have experienced trouble titrating. So it's a pretty classic protocol for psychedelic psychotherapy. Two medicine sessions with prep and integration sessions. Nice thing is we don't have it's not placebo controlled, so it's open label. So it's sort of proof of concept, small study, but it's as we try to find different ways to use these medicines to help reduce some of the harms of the opioid and drug poisoning crisis more broadly. This seemed like a good place where we could start, to see if this is a place where we could intervene, because it is such an issue with people having to titrate down their opioids, and we know that that's such a risky point for people to then transition into using illicit opioids, or transitioning to problematic use. So this is trying to get people on an exit ramp before they experience those difficulties. So that's one big one that we're really excited about, and it's funded by largely by Melissa Etheridge's foundation, the Etheridge Foundation. So we're excited to be working with them, and looking forward to that in fall. The microdose.me trial is ongoing. The microdose.me study, I should say, not really a trial, it's a study. It's still open for registration, so we're looking at V2 of that study. The V1 was, I think, the largest study to date, certainly the largest longitudinal one of microdosing. And we've got a great team with that study, working with Kim Kuipers from the Netherlands and Paul Stamets, and then a bunch of folks from my lab here at UBC and Quantified Citizen provide the tech. They provide the app that people track, and so we're really looking forward to seeing if we can replicate some of the exciting findings from V1 with a second sample, and we also fine-tuned it in a bunch of ways based on our initial one. So we're preparing the data from V1. We've got a couple more analyses to do from the first version of microdose.me, which had several thousand microdosers in it, and now looking at the second one, and I think we'll probably close recruiting on that in a couple months, and then start looking at those data. So those are the two of the bigger psychedelic related projects that we have going on, but there's a bunch of other smaller side projects as well, and from a clinical perspective, as a therapist, I'm still so lucky to be able to work with these medicines early on, and yeah, as a clinical scientist, it's hard to imagine anything more rewarding than to be able to be part of research movement to bring some of these help bring some of these interventions back into practice, and then to be able to actually work with the medicines is awesome. So I'm trying to carve out more time because there's increasing demand through special access and also through more and more trials looking for people, um, with experience in psychedelic assisted psychotherapy, and I'm finding opportunities to help train new therapists. So very busy in the psychedelic space. Some of the main things.
Awesome. I would like to ask a question, a follow up question regarding your answer. So, because you're talking about opioid titration, we would like to ask you why you're interested in cannabis and psychedelics. Like, how can cannabis and psychedelics help resolve the opioid crisis?
You know, I've started off as really being a cannabis researcher, and it's still, I think, sort of really at the center of my research program. I think it's just such a powerful medicine with so much potential, and it's very exciting to me that it's something that people can produce themselves, and it has so many purposes and so many uses. So I think it's a multi-purpose medicine, and cannabis is primarily, in most cases, for symptom reduction. So it's not necessarily curative or disease altering. And reduction of symptoms can lead people in a place where they can get engaged in different behaviors that can be disease altering. But in the case, so like if you have, say, chronic pain, and you can use cannabis to reduce the pain. If you use cannabis to reduce the pain and then take that pain-free time to start exercising or be more engaged in physio, then it becomes disease altering. Otherwise, it's symptom reducing. And it's the same with PTSD. There's more and more studies, a few new studies showing that, cannabis can really help with the symptoms, but whether or not it on its own leads to the remission of PTSD, there's less evidence for that, even though we know it helps people get a good sleep and reduce nightmares and just to have a more pleasant life despite the trauma. In contrast to that, psychedelics I see as more sort of a surgical almost kind of intervention, that it can be disease altering. So the psychedelics are more curative. I think we need both types of medicines. There's sometimes it sounds like maybe it can sound like the symptom reduction is less vital or less important, but so many of the treasured medicines that we have, whether aspirin or other things, are about symptom reduction. I think easing suffering is a very valid goal of healthcare, but so is altering the course of disease, which I think psychedelics perhaps have more power to do. And in terms of them working directly together, I really haven't done much research with both, although I think, in the real world, it's certainly, I would say, maybe it's the rule rather than the exception, or at least very commonplace for people to be working with both medicines, probably in the way I've described, one to manage symptoms and one to really change perspective, change functioning.
Got it. That's so interesting. I never thought about cannabis as being for the symptom management, and then something more curative as being psychedelics. Although I acknowledge the word cure is a faux pas, a scary word, hesitant word.
I think it's okay to. I think we know what you're talking about. You're not if you're speaking as a physician, you want to be to a patient, you want to be very careful. But I think I know what you're saying with curative, and that's why I say disease altering, because is it cured or does it just really change the course? It has effects that don't wear off. It has effects that might extend past the active window of the medicine, whereas cannabis may not.
Got it. I see.
Right,
Cool.
like when you're not high on the mushrooms anymore, hopefully you have a very different symptom profile. Whereas with cannabis, I think we expect the symptoms to return once you're no longer high, or they might, anyways.
Right. Got it. Okay. Okay. I have an interesting question. At the Dose 2 movie screening in downtown Vancouver, there was open questions for the panel of people on the stage. And one gentleman came up and he said that he deals and experiences schizophrenia, and that he's actually microdosing or using psychedelics to help manage that. which for people who don't know the context, people who have psychotic conditions are almost universally excluded from clinical trials involving psychedelics. Now, I'm curious. There's also a connection there with cannabis too. I'm curious on, is there any update on, or what is your opinion on how cannabis and psychedelics interface with psychotic conditions? And is there a difference between cannabis and psychedelics?
Hey, we hope you're enjoying the podcast so far. Now, if you want to support and become part of the psychedelic movement, feel free to donate to MAPS Canada at the link in the description below. Thank you for helping our mission to support equitable access to legal and regulated psychedelic medicines for all Canadians.
Well, maybe I'll start at the end. First of all, absolutely, there's a huge difference between cannabis and psychedelics. Psychedelics, from our understanding, at least from a sort of a reductionist neurophysiology, neurochemistry perspective, psychedelics are operating primarily on the serotonergic system, and cannabis works on the endocannabinoid system. And of course, everything interrelates in the brain. So, the endocannabinoid system might moderate serotonin functioning. It moderates just about everything. But basically, at that basic level, there are different systems, and certainly at the subjective level, they're very different effects. I don't know, people who have used both aren't like, gee, I wonder, I can't recall if I took mushrooms or if I smoked cannabis. People tend to know, although I think it's an interesting question of at high doses, what is cannabis? Is it more similar to psilocybin? But I digress. So with psychosis, it's a big question. And maybe I'll take them separately, because with cannabis, there's been so much research on cannabis and psychosis. And what we know is that people who before they experience a psychotic episode, their first psychotic episode, what's called the prodrome is one way we talk about it, the period where there may be some modest symptoms, but someone hasn't had a psychotic episode yet. So during that time, we know people who use cannabis during that time are more likely to have a full-blown psychotic episode. We know that people with psychosis are more likely to use cannabis than without. So there's no doubt there's an association between cannabis use and psychosis. The real question is it causal? And the jury really is out on that. And given that there's been so much research on it, I think our best bet right now is that it's part of a syndrome, especially when we talk about psychosis, very unlikely to emerge, later than the early mid-20s. So when we talk about cannabis and psychosis, we're very often concerned about young people using a lot of cannabis and then becoming having symptoms of psychosis or getting a diagnosis of schizophrenia. My perspective is I believe they're part of a similar syndrome of problematic, unwellness. So, people, we know that, for instance, young people who engage in fire starting are much more likely to later on have a diagnosis of schizophrenia or to have a psychotic episode. And often they're fire starting in early adolescence, and then they get diagnosed with schizophrenia or something, 5 years later. So they're starting fires at 13, 14. They get a diagnosis of schizophrenia at 17, 18. But you would never say the fire starting caused the psychosis. They're probably related. Someone was having trouble, working within normal bounds or doing, unadvised behaviors early, and then later on they get the diagnosis, but one didn't cause the other. So I think cannabis is much the same way, so that when people are going to start using cannabis pretty regularly, it's usually around 15, 16, and typically when people are diagnosed with schizophrenia, it's 18, 19, 20, 22. So often the cannabis use will emerge first as an early symptom of the syndrome of mental health problems. And so it can appear very much like it causes it, but we haven't been able to really thread that needle research-wise, and it appears that it might just be an early symptom of a syndrome that includes psychosis. there does seem to be, a disruption in reality testing when you see people who are at risk of psychosis or have had prior psychotic breaks. Anything, alcohol use, stimulant is a big one. So stimulant use, we see people, you stay up a few nights in a row on meth, and then that can really lead to a psychotic break, or cocaine. It can lead to a psychotic break that way. So I think, and that's when we get into psychedelics. I think anything that really disrupts that reality testing, it can be stressful. We know a psychedelic experience can be quite stressful. Can lead to exacerbate psychotic symptoms and maybe push people over the edge to have a full psychotic episode. So it's a risk factor, but is it a cause? I think we're out on that, and certainly, in terms of cannabis and psychedelics, have both been so stigmatized. We don't even have to get into the war on drugs, but there's been so much misinformation around these these ancient medicines. And, because you can't point to a physical, people are like, oh, everyone's like, they're terrible, they're the worst. And I was like, well, what's wrong with them? Do they hurt your heart? No. Well, do they hurt do they cause arthritis? No. Do they cause liver damage? No. Well, I thought you said they were terrible. Oh, they'll make you mad. They'll, so this association between these substances and madness is really part of the stigmatization. So I want to be very careful and really look at that with a critical lens. But there is something there. And from a research perspective, we're still at early stages, sadly with cannabis as well. So we tend to go with some of the least risky populations to look at. So, you won't see many trials of psychedelics with adolescents or with or with folks with neurodegenerative disorders, just because we feel these people, cognitively and in terms of their functioning are sensitive. So they're lower on the list when we first start the research. We want to work first with healthy normals, right, to see are these drugs even safe? Of course, we know there's a long history, so we have a good sense. But typically in drug development, you're going to start with healthy normals. Then you start with people who have the condition that you're trying to treat. But first you establish safety. And then once you get sort of the mainstream of the condition, then you might try to look into other things. So right now with psychedelics, a lot of the attention is on PTSD. It's on, mood disorders, depression. It's on substance use disorders, things where we think there's, not a particular risk of negative consequences like there might be with the disruption of psychedelics in people who have psychotic disorders, and also things where we think there's a high likelihood that it's helpful. And psychosis doesn't really fit into either of those categories. It's one that people are reluctant to address because there's, worry that it could be a disruptive, stressful experience that could exacerbate some symptoms. And also because it's not like there's a great indication that psychedelics are going to be helpful. There certainly are anecdotes like what you say, but what we find is, the psychedelic, the mystical experience creates a sense of connection and improves mood in ways that are helpful for depression and can help people get re-experience and process their trauma in different ways, or reconnect with their values in a way that help them change their substance use. And I don't know if we have that direct kind of mechanism with psychotic disorders. So it's sort of low on the list and hasn't made it yet into the research phase. So that's one piece. That's why we're not doing the research on it yet. But when you talk about people like yourself, from an anecdote of someone who's using something like microdosing and they report good effects, certainly the official medical word is going to be there isn't research to hold that up, and as someone who's at risk of psychosis, you probably shouldn't be using any consciousness altering medicines. Those messages are out there, so it's not as if the person you spoke to is one caution, one like finger wagging away, like don't do that. They've heard that. So whether we feel that that's our role, that's a personal thing from clinician to clinician. There's another perspective that the role of the clinician is to walk beside the patient as they live their life and guide their health, and we try to help them and are there to support them in their decisions. So if I was seeing a client, they would ask me, boy, what do you think about this microdosing? I'd say, what do you think about it? Why are you doing it? Do you think has anyone told you not to do it? And they'd say, oh yeah, it's all over there. Don't microdose. So what do you think the worries are? How does that fit with your own experience? Why are you doing it despite all those cautions that you already know? So I try to, if people are doing things to help with their health, I want to just learn more about that individual case. And sometimes I can say, the research shows that there isn't support for that, or no one's asked those questions yet. I don't know. Hope that sort of gets at it.
Yeah, definitely. Thank you so much for that answer. I just wanted to delve a little deeper into psychosis. There is this UK researcher who says that I figured psychedelic therapy must be addressing the root of the problem rather than suppressing the symptoms. And this and your answer sort of reminded me of this paper I had read by Mark Hayden, who was talking about some people who were suffering with bipolar disorder and some other things who had by mistake taken a high
Mm,
dose of LSD or high dose of psychedelics, which actually helped them. It got them out of that. So,
mm.
what do you think? Like, why is there such a, like, I get it that, of course, the risk of psychosis and the risk of somebody getting schizophrenia is really high. Um, but do you think that there is a possibility that microdosing psychedelics can help with these diagnoses?
You know, so as a scientist, which is sort of, I think, why you have me on as a expert. So I speak as a scientist. So as a clinical researcher, is it possible? Is not the kind of question that I can, because I think a lot of things are possible, and I tend to believe people, especially when it comes to mental health. I believe them more if someone close to them is saying that too, because sometimes our own perceptions can be deceptive. And we can all think about, in the case of say someone with bipolar disorder who's using stimulants, and you might talk to them on day two of a run, a manic episode fueled by meth, and they'll be like, "This is the best thing that I've ever done for myself. I can't believe how great I'm feeling. I'm having 1,000 fantastic ideas. There's investment opportunities all over, and I'm absolutely my best self." And you're like, "Well, I don't think I would encourage you to go to this place again for your own well-being." But if so you have to take it with you take self-report with a grain of salt. But having said that, it's people are experts on themselves. So if someone says they're doing better, whether it's by doing cold plunges or microdosing or whatever it is, I would never recommend it, because it's not coming with the weight of that empirical authority. But I wouldn't also say, because we don't have the research, your experience of your own life and your own consciousness is meaningless. I would say, take a good look at that. Have you talked to the people around you, the people that care about you? If there's an agreement between, if your grandparents think you're better, and your partner thinks you're better, and you're getting along great with your pets, and it also seems like it's helping you, well then, that's pretty good evidence. If it's just you and everyone else is like, "Please stop microdosing, man, you're not," and you're like, "No way, I'm the best me," and everyone's like, "We're not talking to you anymore," that's not great. So you want to get some confirmation from others, and I think that can be one of the risks of psychedelics and of self-improvement in general, is that often we just turn so much into ourselves and are like, "What's my regimen? Am I doing better? Am I feeling more connected?" But you're spending so much time watching YouTube videos on feeling connected that you're actually not getting out into community, and you're not trying to be of service. You're just on this navel-gazing spiral of self-improvement. So I think connection and community are good measures, other than your perception of how much you're keeping up with certain benchmarks of self-improvement. How are you connecting with community? How is it helping you? So anyway, I think those kind of questions, whether you have psychosis or not, are the questions that people can ask themselves. If they want to ask me, I can only really speak to the evidence, and the evidence is that things like psilocybin seem to be effective for treatment-resistant depression. There's reason to think that in other conditions like substance use disorder that are so comorbid and trauma-related disorders. I can see the mechanism. There's some evidence that they're effective. It makes sense to me. So those are the things I'll speak on. But otherwise, people should, figure out what works for them, consult with their healthcare providers, and consult with their loved ones to see am I really living a better life.
Got it.
And never
I love that, man. The healing in community is so key, and the accountability that comes from that is really important. Like if you think, if one person says something about you, who knows? But if 50 people say the same thing about you, then what is truth? Like,
and do you have, and it's a good sign if you have people that you can ask, and you have that community that is holding you accountable. You're probably 3/4 of the way there, and whether you microdose or not, you're lucky to have a circle of people that care about you and that notice your changes in affect and cognition.
Yeah, got it. Okay. I have a question I have been begging to ask some microdosing researcher for a long time about microdosing psychedelics and its benefits in general. So you could say, if you asked if microdosing will make you taller, microdosing psychedelics will make you taller, and a bunch of people report that it does, that is likely to be a placebo effect. That's just because psychedelics are not relevant for making you taller. So if you're testing psychedelics for a bunch of random things that maybe aren't relevant to what they do, then it's going to come up as placebo or ineffective or otherwise. So I'm curious if in your research with microdosing, and maybe this is your intentions for the V2 study, what can we say? What can we be more confident about that microdosing does, and where are we at with that?
Yeah, it's a great question that everyone, I think, is very curious about. And just let me get back to the last one. So, as a clinician, I would say to someone who has a psychotic disorder that you want to be very careful to maintain your ground state, and that anything that is going to alter your ability to reality test and engage in day-to-day activities is problematic. So you want to stay grounded, and I think stay free of psychedelics if you have psychotic disorder. Just to give a short answer after my very long-winded and thoughtful answer, that's my professional answer. Yeah. Placebo effect. So placebo effect is an interesting thing, right? The idea of the placebo effect, and there's a bunch of different things we can think about that. Like, is it it's rarely is it a placebo. The placebo effect is when you get an inactive treatment and it has an effect, even though it's neutral. And you think, and typically you think you might be getting something else, right? Like you didn't get the active condition, you got the placebo condition, and yet you show a change. So when we think about people who are microdosing, they're not getting the placebo condition typically. So I think what we're asking is, what are the direct effects of what are the direct physiological effects of the drug, and do they actually work the way they work? And I think your example of height is a very good one, because with height, you can think you're getting taller, but someone can measure you and they can say, no, you just feel taller. You're not taller. But it's not quite the same with some of the things that we're looking at with things like microdosing. And, a lot of the time when people are talking about microdosing, the goals are frustratingly vague. So, if you think about the extreme case of microdosing, and I don't agree with the idea that microdosing is subperceptual, right? I think people can tell when they microdose, and we know that from the research, that when they've tried to blind people are like, yeah, I'm on the microdose. And that's not just microdosing, that's SSRIs too, all the drugs. The whole placebo control for mental health is a problem. To get back to the idea of height versus depression or anxiety and the things we're looking for with microdosing, they're not objectively measurable. So if you say I'm feeling less depressed, someone can't say, actually, let's measure you. No, you're not less depressed. A lot of feeling less depressed is like having if you say I'm feeling less depressed, then that means you're hopeful for the future, right? I'm feeling less depressed, I'm going to keep getting less depressed. Okay, well, you have hope for the future. One of the symptoms of depression is I have no hope for the future. So there's a lot of subjectivity in these criteria. There isn't a blood test. There isn't a tape measure that you can use to say whether or not your perceptions match on to some objective pathology, right? And often it's not even pathology. It's people are looking to feel things like more connected. And they're doing an intervention that they can't even feel. In theory, right? So you have an intervention. It's very much like CBD. So how do you know if you're on CBD? Oh, you don't. It's totally transparent. You don't feel anything. Well, what does it do for you? Oh, everything. I'm more connected. I can concentrate better. My workout is better. My sex life is better. Everything is better. Really, what does it feel like? Oh, nothing. It's nothing. It's nothing, and it improves everything. So yeah, that's unlikely. That something has both no effect and a general enhancement of anything. And with microdosing, we have at least some ideas about dosage, but it's pretty loose. If most people are taking a certain amount of a psilocybe mushroom, they have their typical, I take a piece the size of my thumb. Well, we know that the amount of psilocybin in that stem can be 600% variation, even among a single flush. So it's very hard to know what you're dosing. And then if you make, claims about effects without knowing the dose, that's also very problematic. And with CBD, just to extend that analogy, it's even wilder because nobody really, people take huge differences in dose and claim the same effects or opposing effects. But is it doing anything? Yeah, there's evidence that it's crossing the blood-brain barrier and that it is impacting the serotonergic system, the serotonin system, in a bunch of ways, which we know impacts mood and impacts the very things that we are that we expect it to work on. So it's not like it's making you taller. It's impacting your, people say, oh, it helps me improve my mood. Well, the idea of tweaking the serotonergic system, SSRIs are a different pathway and a different receptor, but still the idea that you would have a low-key modulation of the serotonergic system and that would impact your mood, it's not exactly out there concept. So there's a premise of why it wouldn't be inert. The other thing is that people can tell when they're on psychedelics, and so they can interpret that on microdoses even, I believe. I think so, from personal experience and from reports. Most people can know. So if you're feeling the way you're feeling and you track that as feeling, I feel better, I feel less depressed, I feel more energetic. Is it that are people saying you're feeling the microdose, but you're misinterpreting that feeling as being positive when actually you're unhappy? You're just calling it happy because of a placebo? Like, does that make sense? So I think, we want to use this term placebo effect, but I think when we start to dig into what exactly does that mean, people are taking a drug, they're having a predicted response to it, they're reporting that response as being positive. What are the long-term consequences of it? We have a paper that's under review right now showing that most of the microdosing effects seem limited to the days when people microdose, which is not surprising. So maybe it's more like cannabis in the sense that you get, and I love Occam's razor. I love the simplest explanation you can find. So if you take a little bit of psilocybin, you feel a little bit high. Things are a little bit, maybe perhaps for you, you feel more emotionally regulated. You have some of those insights at a lower rate, but that you're more connected to values in some ways. Your mindfulness. That's the number one reason we saw people taking microdosing was to enhance mindfulness. Again, a vague concept, but I think people, maybe you're more aware of your thought process and therefore more able to alter it or to challenge it in some ways. If people are reporting that, and you're like, no, that's a placebo effect. We don't have the kind of measurement where we can falsify those reports. So we can't say, no, actually you weren't more connected. If down the road, and I wouldn't be terribly interested in this research, but maybe someone else would, you could wear some kind of a fMRI hat and people would say, oh, look, the parts of your brain that are associated with empathy are actually not more active. Would that even be better than people reporting feeling more empathetic? Would you say, well, the screen here says you're not more empathetic, so it's a placebo effect? So I guess I challenge the notion of placebo. And what we have is people taking a little bit, in most cases, of a mushroom, saying it makes them feel better. We need to know what the negative consequences perhaps are, so we want to be careful to monitor the risks. But the question is whether or not people are faking themselves out. I don't know. What do you think?
In my personal experience, I've microdosed a bit, and I've noticed for me, I have always combined it with meditation. And so it's hard to parse what was the benefits of the meditation versus the microdosing. I found with the microdosing, I'd be more called to meditate. It was an interesting effect that I experienced.
So, that's it, right? Like sometimes when you microdose, let's say you say, I'm going to microdose today. I'm going to go for a long walk in nature. And you have an intention for that day, which is sort of part of why you're microdosing. And then maybe you notice the microdose and you're like, oh, I'm meditating and I'm microdosing, and this is neat, this is different, and it reminds you of why you did it all in the first place, which is perhaps to work on your mood or to be a better partner or whatever it is that you're trying to do, and just managing that intention and maybe having that little psychoactive effect that continually reminds you through the day, why is the avocado so shiny? Oh yeah, it's because I microdosed today. And why did I microdose today? Oh yeah, because I'm trying to be a better parent. And then I'm like, oh yeah, I'm trying to be a better parent. So is that a placebo effect? Is that due to microdosing? Is it due to, if I were to tell you the parenting chemical in my brain that's being either facilitated or inhibited, does it even matter? I hate to answer a question with a bunch of questions, but I know people would love to have a yes, no to the placebo effect. And I want to say, what do you mean placebo? What do you mean effect? What are you looking for? In what context? I will tell you that in our, and it could be a spurious finding, we're looking to reproduce it in microdose Me Too, because it's quite unusual and pronounced, but we found more effectiveness in older adults on the TAP test if they were microdosing lion's mane and niacin together with psilocybin versus just psilocybin alone. So that could just be a random statistical aberration. There could be another factor that's driving it. But if not, then the main difference we're looking at is whether or not these are people who are all microdosing, some with the stack, some without. That'd be a weird placebo effect, right? Because it'd be a placebo effect that's only hitting the older adults, and it would be a placebo effect where you don't get the full placebo unless you use the stack. Like where does the placebo? I want to know where the placebo effect stops and starts. Like, can you just keep taking more stuff and getting more and more placebo effect? So do you have your valerian root placebo, and then on top of that you have your psilocybin placebo, and then on top of that you're doing cold plunges, which may also have a placebo effect, and then so how much placebo can I get? That's all I got. I've talked myself into
Awesome. Again. Thank you so much for that answer. So talking about microdose, we would like to ask you, what is the recommended duration for microdosing, and is it possible to have harmful effects from chronic microdosing?
Well, I think the harmful effects is a good question. We know that taking large doses of psilocybin very rarely, so most people, even if they're using it regularly, it'll be a couple times a year, maybe more than a couple, but not very regularly. Very few people. Most people have one or two psychedelic experiences a year, even if they're psychedelic users. And we know that seems pretty safe. There isn't a reason to think that would be very harmful beyond the threats of mental illness that come from altering your sense of reality, and we don't know how valid those are. But in terms of the physiological safety, they seem very safe. When you're under the acute effects, it might be dangerous because you're disoriented. You want to have a sitter. You have to have a sitter. Otherwise, all kinds of bad things could happen. But really, physiologically, as a medicine, psilocybin at least seems quite safe. If you take if you have a psychedelic dose a couple times a year. We don't know what the long-term down or upregulation effects are of microdosing. We just don't know. There haven't been a lot of people microdosing for a long enough time that we've been measuring for us to know what happens if you microdose for years. So I think that's a really important question. It applies to a lot of medicines and a lot of vitamins and a lot of supplements. We just don't have the evidence on what happens if you take if you do this thing that's going to alter your physiology in a low-key way for a long time. Sometimes long-term modest changes can have a negative effect that you don't see with an acute effect. So the answer is we don't know what the long-term effects of microdosing are. I don't think there are huge red flags. There's some concern around that there could be some serotonergic effects in heart functioning. I am not the best person to ask about that. I'm a clinical psychologist, but I understand there's some concern there. So yeah, we don't know. We don't know what it does in the long term. So there's that risk. What was the first part of your question? I'm sorry.
I was asking if
best quantity and program, and
yes,
for that
the recommended duration.
I don't know.
Okay.
We tried to look at it. There's those, and I don't want to advise anyone on that because again, I don't have the information to know what's best. Our most recent findings that are now under review, so they're not peer reviewed yet, but they suggest that the effects last for the microdosing day and that there aren't carryover effects. I think part of the thinking with the different protocols is that you do a washout so that you don't gain tolerance. We know that with high dose psychedelics, if you try to take psilocybin mushrooms a day after you've had a high dose experience, you'll have a diminished or negligible experience because of this acute tolerance. So we don't know if that happens with the small doses, but I think, to prevent that, people say take a day off, let your system wash out. So I think that's what's behind those, but I can't speak to whether or not that's true. When we try to unpack it with our data from V1, it just became very complicated, partially because of the way we asked the question, did you microdose today? And people didn't answer every day. And then we'd say, what's your typical pattern? And people would say, I do this and this. But most people, there are so many different patterns and so many differences in what people were taking that we couldn't find enough reliable patterns where we really felt we could analyze it and say anything. Hopefully in our next set, we have a more reliable way of testing these different protocols. But for now, I really can't advise one way or the other. And we don't even know if it has any beneficial effects at all. So to start picking between things where we don't know if any of them work, that will be something for down the road.
Got it. Given Paul Stamets is involved with the study, we must endorse the Stamets protocol as the. I don't
think Paul would ask for that. As in so many cases, I think some of the people who swear by it are more strident than the originators of it. I think if you talk to people like Fadiman or like Stamets, they have their ideas, but they say, I came up with that, and I don't pretend to speak for them at all. But having worked with both of them a little bit, they're quite humble and curious about their protocols. They're not authoritative. And, I don't think there's been a Stamets versus Fadiman face-off over what's the proper protocol or anything like that. I think we're all curious. We're all trying to figure out what's best and eager to hear from people about what they're doing and how that works.
Yeah, we need to get them on the podcast to battle it out to the end.
Yeah.
Okay, so you mentioned V2, so the round 2 with the microdosing study. And I'll ask generally, what are you looking to do with the V2 that growing on V1?
Well, I think the big one, for me, one of the big curiosity for me is can we replicate those TAP findings in a totally new sample? Because that's interesting. And again, with a finger tap, it's not something that is so amenable to expectancy effects. Like I said, with, the depression, people are saying, do you feel better? Well, I'm they might think I'm supposed to feel better because I'm microdosing to feel better. Therefore, is it an expectancy effect? Is it reactivity where people, so, to reframe that placebo, is it people responding in a way they think they want us to, we want them to respond, or what have you? With a tap, I think, it's a little bit more objective. So I'd be curious to see if we see changes on that again. We're diving a little deeper into different conditions, so being able to break it up according to what people are intending their microdose to be for, informed by why people are microdosing from V1, so we now have different tracks. So getting a little bit more granular information on that, hopefully unpacking a little bit more of what potential differences there are amongst different programs of microdosing.
Amazing. Thank you so much. Now, moving a little away from microdosing, we would like to ask you. So, recently, the US FDA advisory voted against MDMA therapy. And also, the good news, on the other hand, is that after a ruling by Supreme Court of Canada, Health Canada approved psilocybin therapy for a patient with cluster headaches. So, when do you think it will be possible for psychedelic medicine to reach people who actually need it?
Wow. So there's a bunch of different medicines in there, and there's a bunch of different people who need it. Right now, for some people who need it, there is access to psilocybin through the Special Access Program. It's hard to say, what do we mean by accessible? And there's so many different barriers that can come up. So if we were to legalize psilocybin tomorrow for any purpose, so you could just buy it in a store, or to follow a model like Oregon, where there's sort of limited training for providers and it doesn't require a reference in the same way from a healthcare provider. You could make it, we could say, yes, you can have psilocybin treatment on the recommendation of a psychiatrist, at which point we'd have to ask, what are the wait times for a psychiatrist? So even with legal changes, having access to those who need it, I think, is going to come up against some very real and problematic limitations of our mental health care system, which is still not on par with our physical health care system by any means. We don't follow people up. We don't take treatment seriously. So when we talk about a new treatment getting to everyone who needs it, that's going to take some real renovation. If we're thinking about when will the regulators approve this as a prescription medicine, the way they have, like, let's say, ketamine, which is still far from available. So you think, yay, we have ketamine, but who gets ketamine? And who's using Spravato? And is, in fact, the approval of Spravato, do you guys know what I mean by Spravato, the intranasal ketamine that's very expensive and available on prescription? And what we see is a lot of folks going to private clinics and getting IV or intramuscular ketamine. And that's somehow in the shadow of Spravato being approved. I think that gave people confidence to be able to do these other treatments because a version of it's approved. So what will be approved and how will people get it, and how will the public and semi-private systems interact to deliver it? I think those are all complicated questions. And I don't, I think there's been an unfortunate amount of hype from largely from, some well-intentioned optimism, others profiteering by startups to say, we're going to be turning a profit this time next year. They don't know what they're talking about. I don't know. I think things are moving in a positive direction, which is nice. They're not moving fast enough. They're not moving fast enough, and that goes for mental health care more generally. So people who are at risk of death and serious injury due to their opioid use disorders are not being identified and being treated in a way that can help preserve their life. So there's a lot of room for improvement when it comes to service delivery and access, even once we get past regulation. And when it comes to regulations, I have enough trouble guessing when my study is going to get through Health Canada approval and the second revision of the Research Ethics Board, whereas I can't say when Health Canada is going to meet, and there's so many considerations there politically, and who wants it to happen, and who's going to champion it, and who's running for re-election, and all that stuff plays into it in ways I can hardly predict. Sorry.
Got it. Yeah. I just had to unmute myself. Yeah, big question. Access is a big question, and something MAPS Canada is like a big, one of our big emphases amongst other things. And so I'd love to ask you about our EXPAND study, and I'll give some context for the listeners for what that is. So EXPAND is an acronym that stands for the Exploratory Study of the Determinants Impacting Access. So basically, the way to think about it is that psychedelics are currently illegal in Canada and can't be obtained by doctors or given to patients without special permission from Health Canada, aka the government. And one avenue to get permission is called the Special Access Program, the SAP. And through the program, licensed prescribers can apply for permission to treat their patients with psychedelics. To do so, they have to show that the patient has serious life-threatening illness and that they know how to provide psychedelic-assisted therapy, and the application is complex. And then permission is granted from Health Canada on a case-by-case basis. So you can imagine needing like a thumbs up from Justin Trudeau every time you want to sign up for like a yoga retreat, for context. And to date, like not many SAP applications have been successful, although some have. And recently, of course, there's a psilocybin therapy for someone with cluster headaches. And with the EXPAND study, we're looking to address issues with the SAP by engaging with prescribers, get a better understanding of what the barriers are, and in people applying for the SAP application. Now, Dr. Walsh, you were involved with the EXPAND study for MAPS Canada. Could you share with us how that went, your involvement, and your perspective?
Well, I believe there's still, I helped, I wouldn't take a lead on that, so I don't want to take too much credit at all. I think I assisted with developing the questionnaire, and I think it's going to deliver some really interesting information around what are some of the barriers, and that stuff is so valuable, you know. I really love that kind of practical, community-based research where we're finding out what's actually going on. You know, we can write more and more essays about the ecological impact of psychedelics, consciousness expanding, and really, I think people can get really into some of that more esoteric, and I think psychedelics sometimes lead people towards esotericism in ways that may not be helpful. You know, there's a lot of grand theorizing around psychedelics and how they're going to change the world, but I like the research that says how do we get them to sick people who might benefit urgently. So I'm really excited by the EXPAND study, but and you know, I wondered, just to get back to your regulatory question, is what will really happen with psychedelics, and how do we see the regulation rolling out? So will we wait for it to be a fully approved medicine, and then how is the healthcare system going to accommodate that? Or will we see for something like psilocybin, maybe what we have for cannabis, where there's a broad legalization, and that empowers people to use it as they see fit, and then work with a therapist, so you have psilocybin and therapy. And of course, that's not ideal. We'd like to have them integrated, but is that going to be there before we have fully regulated access? I don't really know. I think we want to just keep an eye on what's important, and I think what's most important is that people are able to exercise their liberty to take care of their health in ways that are beneficial to them, and that recognize their autonomy, especially when it's not going to be too harmful. And if that means expanding SAP and working for broader legalization and all of that stuff. I think all of it at once is what's needed, and I just urge everyone to sort of advocate where their heart is.
Got it. Yeah. So we have a fun question. If you had Justin Trudeau in a room with you right now, what would you say to him?
So I would tell him to good work on cannabis, and look at, after there's some initial concern, it turned out to be something that increased the liberty of Canadians and allowed people to, live life the way they wanted to without really doing much harm or any harm, and considerable benefit. And people aren't getting arrested, and so, think about whether or not you want to build on that. And maybe psilocybin is something that doesn't deserve to be illegal either. And look at it,
Got it. Okay. Well, we can wrap it up there. And Roisin, if you'd like to say thank you too.
Yes, thank you so much for coming to the podcast. It really means a lot. And yeah, thank you for answering all our weird questions.
Yes.
I'm David Bronner, Cosmic Engagement Officer at Dr. Bronner's, board member of MAPS. Subscribe to MAPS Canada. Bam!